Hello and welcome. Yet another episode of Kera Journal Club, and this is second Journal Club which we are hosting today. As we were discussing last time, we thought Journal Club can be taken up in a couple of ways. One, we can critically analyze an article and give our opinion about the article, or we can take something which is more clinically relevant to everybody. And this time, the team has come up with an article which is absolutely relevant to everybody. And it's something which is worth discussing upon, and beyond the article also, the discussion can be quite useful. Over to you, Parul, hoping for a wonderful discussion today. You're muted, Parul.
Yeah. Thanks, Himanshu. I think from here, Aditya is going to take over. Aditya.
So thank you all for joining us on this evening. So basically, the article in question is how to cross-link corneas which are ultra-thin. So as we all know, corneal cross-linking is a very well-researched and a very clinically proven tool to arrest the progression of keratoconus. But ever since the introduction by Wolensak, 400 microns has been the magical number, both to adequately cross-link the thin cornea and prevent endothelial damage. But as we all know, many of the cornea, the patients which come into our clinics, do not fulfill this magical number. Many are on the lower side of this. And it's always a dilemma, how do we stop the progression of this disease, yet provide adequate outcomes and safety for the patient. So Dr. Hafizi and his team have come up with this wonderful article, this algorithm, in which they have exclusively selected patients not fulfilling this magic number of 400. And then they have given a nice algorithm on how to cross-link these ultra-thin corneas based on the energy and the varying time intervals. So now I will like to invite Dr. Charuta, who is a senior consultant ophthalmologist in Hyderabad, to share her screen and then start the discussion on the article itself.
Good evening, everyone. At the outset, I'd like to thank CSI, Dr. Parul, for selecting me and allowing me to present this article. It's been a wonderful journey in the last 1 week. So the article in question is individualized cross-linking with riboflavin and UVA in ultra-thin corneas, called the sub-400 protocol. And casually, when I browsed the website, it says the future is now. So I'm going to be a little skeptical, although I'm a big fan of Dr. Hafizi myself. Now, we know that topical application of riboflavin in the cornea leads to loss of equilibrium in the riboflavin molecules and generation of free radicals when it is exposed to UVA. Now, riboflavin becomes unstable, destabilizes itself, and then stabilizes itself by linking to collagen fibrils. This leads to the formation of a series of bridges. So this was a brief introduction of what happens during collagen cross-linking for the uninitiated. Now, like Dr. Aditya was saying, we always follow this magical number of 400 microns. And if we combine the cytotoxicity studies And based on the studies that were done in porcine and rabbit eyes, this magical number was reached. So we have assumed that an absorption coefficient of 53 per centimeter for UVA is what happens. Now, the absorption coefficient is something that denotes if there is light passing through a medium, then how much of it is reflected, how much of it is absorbed, and how much of it gets transmitted. So in the question of cornea, the more the absorption coefficient, the safer is our endothelium. So later on, these were the studies that were done on rabbit eyes. So later on, absorption coefficients by Coppen et al. Were found out in cadaver to be 32, which is actually much lesser. Therefore, it means that our magical number of 400 doesn't really hold accuracy. Now, if we go to further, if we try to probe further on this aspect that our magical number is not really true, we have several publications which follow that this protocol and then say that it is actually safe. So all these 7 studies have summarized and have actually documented both pachymetry and endothelial cell counts in cross-linking eyes, and all of them have concluded that there is no difference in cell counts either before or after cross-linking. And they have actually abided with the 400 magic number, although it was actually including the epithelium. Now, as in a stark contrast, there is paucity of evidence of endothelial toxicity as well. There are 3 case reports which say that the endothelium was damaged, but they have no records of the pre-operative endothelial cell density, and probably there were some treatment protocol errors as well. 10 cases have post-operative corneal edema, in which inadvertently there was close irradiation. And confocal study, there is one study which says that there was significant decrease in the endothelial cell density before and after. However, if you observe, there is the variability is very high in the after measurements. Now, coming to another aspect which will be dealt with in the article, that is the riboflavin. Now, we know commonly now that isoosmolar riboflavin towards the end of the procedure leads to corneal thinning intraoperatively, and a 60-minute cross-linking actually decreases the thickness by around 87 plus minus 40 microns, which was shown by Holopainen et al. Another aspect is now a drop called Ricroline and Ricroline Plus. That is, Ricroline is standard dextran plus riboflavin combination 0.1%, and plus meaning the addition of permeation enhancers. So these molecules that are mentioned in small are actually taken from the patency document for Ricroline Plus. Now, keratoconus progression has been defined variably by various trials. These are the criteria mentioned in the CNR trial, which was way back, and more recently the Berlin ABCD grading system is what is used to define progression. If we see, a multitude of factors are taken for assessing and saying that the keratoconus is progressive. Another caveat is the demarcation line, which is an indicator of the transition between a cross-linked stroma and untreated tissue. This can be seen at 2 weeks, and actually the hyperreflectivity is due to the difference in the refractive indexes of cross-linking versus the untreated stroma, which probably tells us the depth of the treatment. This has also been shown to be true on anterior segment OCT and confocal microscopy levels of the demarcation line, which showed no statistical difference. The last point that I want to touch upon is treatment failures in cross-linking. Now, this was an article from Theo Seiler et al. In which they have mentioned that a higher preoperative max K is a significant risk factor for failure, and which was approximately 7.6%. Coming to the article in question now, this article was published in American Journal of Ophthalmology 2021 in April by Dr. Farhad Hafizi and his group. Now, the study protocol, they have mentioned that it was ethics committee approval was taken for retrospective data collection, and the study design was described as retrospective case analysis. The period was defined between 2016 and 18 and conducted at the ELSA Institute in Switzerland. The inclusion criteria were progressive corneal ectasia, which was defined as change of 1 diopter on the differential maps of anterior sagittal curvature, and the max K for the maximum K was used for non-electronic records. Primary ectasia of between 9 and 19 years of age was also taken as it presented without any documented progression. All corneas had a stromal thickness less than 400 microns, that is excluding the epithelium. Exclusion criteria was more than 10 packets of smoking, pregnancy, pre-existing trauma, surgery. Also, inability to understand the nature of study or give consent was also mentioned in the exclusion criteria. Number of participants included 39 eyes of 32 patients, maximum of them were between 21 and 40 years, with 8 between less than 20 and 6 more than 40 years of age. They were assessed at 1 month, 1 year postoperatively, and assessments included corrected distance visual acuity, refraction, biomicroscopy, and the demarcation line, which was assessed at 1 month. This was assessed by the same observer, and the measurements were taken from the thinnest point of the pachymetry. So the method has been described is that central 9 millimeters of the epithelium were debrided. Then Ricrolin plus was used. Soak time of 20 minutes was taken. Cross-linking at T65, intensity of 3 milliwatts, and the treatment time was varied depending on the previously published data. So pachymetry was initially taken at every 5 minutes, and at the end of the soak time, the thickness was measured. This thickness was utilized keeping a demarcation line target of 70 microns from the endothelium. This was the nomogram that was previously published. Now, statistical analysis, they established normality versus non-normality of the data by the Shapiro-Wilk test. For all normally distributed data, the two-tailed t-test was used, and not normatively distributed, the Wilcoxon sign rank non-parametric test was used. So at this, I'm going to introduce a small statistical capsule in which we learn something new about statistics. So how do you draw a trend line on a scatter plot? Now, the trend line is actually a straight line. We see it very often in if you are investing in shares. It's a straight line that best represents the points. It may go through some, but need not go through all the points. It is used to show the pattern of the data, and it must pass through as many dots on top as below. It may show a positive or a negative trend. And for more detailed statistical evaluation, an equation can be written to describe the line. Now, the outliers must be disregarded. Coming to the results section, the corrected distance visual acuity showed no difference at 1 year. The demarcation line, from the demarcation line to the anterior stroma, the variability was 275 plus minus 61, and to the endothelium was 93 microns. And the variability was between 0 and 250 microns. So the thickness of the cornea ranged between 214 and 398 microns at the end of the protocol. In one eye, it was between 214 and 250. 3 eyes, 251 to 300. 16 eyes between 301 and 350. And in 19 eyes between 351 and 400 microns. The keratometry was stable or improved in 35 of 39 cases, of which steepening less than 1 diopter was seen in 3 eyes. And flattening up to 1 diopter was seen in 8 eyes, 1 to 2 in 14, 1 to 3 in 4, up to 8 in 3 eyes, and more than 8 in 3 eyes. So in 4 patients, the steepening, there was worsening of the keratometry, which were classified under treatment failure. So they also measured densitometry, which was not mentioned in the methodology, which showed statistically significant increase from baseline at 12 months. All patients remained within the typical clinical presentation of mild opacity after the cross-linking. Now, the authors have concluded that sub-400 protocol was able to successfully prevent keratoconus progression in ultra-thin corneas in 90% of their cases after 1 year of follow-up. They admit that limitations they point out that the limitations of other methods, like in hypoosmolar riboflavin, which may have variable swelling, in the case of contact lens cross-linking, in which there is 30% reduction in stiffening, In the case of epithelial island related cross-linking, there may be an unequal demarcation line and unpredictable results. And also the theoretical proposition of altering the riboflavin concentration, in which there may be a shallower cross-linking reaction. So these limitations make their method slightly superior to the others. Now, the algorithm itself, in the algorithm itself, they say that the stromal riboflavin, oxygen, and UV availability during the cross-linking is defined by the fixed law of diffusion and therefore is actually quite predictable. So they also say that estimation of the UV energy by the Lambert-Beer law of light absorption makes it a predictable outcomes. And the speed and the amount of photochemical reactions are defined by these two laws. Now, the accuracy of the sub 400 algorithm has been confirmed by porcine and murine studies. And clinically, however, in this study, the thinnest pachymetry was 325 microns. They admit that the limitation was that 15% of the eyes were over 40. However, out of the 4 eyes that failed, two eyes belonged to the same patient, and that patient was above 40 years of age with an uncontrolled hypothyroidism. They also admit that only one parameter was used for assessing or establishing progression, and that endothelial cell density could not be assessed. Also, they admit that subtle endothelial signs were not documented or assessed, and that demarcation line depths demonstrated considerable variability. They also point out that experimental evidence traditionally overestimates the actual threshold of damage. So coming to my interpretation, I think that in the study design methodology, there are some obvious pointers. That is, the enrollment of patient and patient consent were mentioned in the same paragraph, although it is a retrospective study design. 1 year, one diopter was taken over a year as the progression, which is a long timeline for establishing progression, especially when there is only one parameter that we are taking into consideration. The presence or absence of allergy or its control has not been mentioned anywhere in the article. Also, if Recriolin Plus is having permeation enhancers with it, why was it used with epithelium off, and why was not Recriolin alone used? That would have helped us to apply it to our the molecules that are available to us. Now, also in the statistical assessment, the demarcation line itself, the trend line that they have drawn, 33 are above the line and only 16 are below it, and also too many outliers seem to be present, therefore making it very difficult to actually say that the trend line is probably accurate or not. Also, the experimental science that has been done recently, I came across this article wherein they took the studies that said that our calculation of the absorption coefficient was inaccurate, and they took the endothelial side up and treated it with the same protocols that we do for cross-linking, and they found no statistical difference between the corneas that were preserved in preservation medium and those that were subjected to 0.25% riboflavin from the endothelial side up, which means that at least in the short term or for the duration of the study, there was no effect on the endothelial cells or their cell density. So coming with these in mind, the basic science studies point out towards questioning the need for a modified protocol at all, if at all, in cases of ultra thin corneas. These are, however, and further supported by the paucity of case reports, as I demonstrated in the initial literature review. Also, despite all my points against this article itself, unless we have long-term data of decompensation available, we cannot actually say that it's probably safe for even thin corneas. Thank you very much for your patient listening. I now request Aditya if he has any further points to add to this discussion.
Oh, thank you, Charuta, for a wonderful presentation. Really a very nice presentation that you made. So before we really go on to the discussion of the article, I would just ask Aditya to give us a literature review on the thin cornea cross-linking therapy. So Aditya, can you share your slides?
Yeah. So yeah. So the slides are visible.
Yeah, they're visible.
Yeah. So thank you. So basically, I'll be giving a brief overview on the management options we have in our armamentarium in advanced keratoconus cases. So it will be including not just cross-linking, but some other modalities as well. So basically, we start off with the contentious issue is what do you call as an advanced keratoconus? So as usual, there is no clarity in the literature. Many cases are labeled as advanced, sufficiently advanced, moderately advanced. So no clear clarity in the terminology. So, but two things which are very clear is that one is that the patient has an unacceptably poor best spectacle corrected distance visual acuity. So that is one criteria which is common in almost all the publications. And the second is that the patient is highly intolerant to contact lens wear. So these, if you consider these 2 points and label the patient as having an advanced keratoconus, the advantage is that it is quite reasonable to understand and expect. It is also useful in normalizing the terminology across publications. And the main thing is it is independent of the imaging devices you are using to diagnose the patient, and also the various grading schemes which have been touched upon by Charuta in her presentation. So basically these 2 points, if you consider, and then you can label the patient as having an advanced keratoconus. So the different modalities which we have is basically, one is a full thickness keratoplasty or a DALK. The other one is something which we call as an additive keratoplasty. The third option is Bowman layer transplantation. The other option is cross-linking. And the final fifth option is an intracorneal ring segment. So for the purpose of time, I will not be touching upon PK and DALK as they are the last options in all these 5. So I'll briefly deal with the rest of the 4. So coming to Bowman layer transplantation, it was first described in and published in 2014 by Gerrit Melly's group in 10 cases of having advanced keratoconus. In their publication, no immune rejection episode was reported because it is basically a cellular tissue. The recent publications have also explored the possibility of an onlay graft in the subepithelial area. So no pocket creation is needed. You just create the donor tissue and place it on the corneal surface. So in this publication in Graphes in 2018, the 5-year progression or a complication-free estimated survival rate was around 84% in patients who are undergoing Bowman layer transplantation over 5 years of follow-up. If you go to the second option which we have in the list is basically additive keratoplasty. However, in the literature which I have gone through, there are various confusing terminologies with difficult short forms to remember. One is Philly, one is called as silk, somebody has called it slack, somebody has called it FASK. So very difficult to remember, but basically you have the keratoconic cornea. You use the femtosecond laser to do the creation of the pocket and well as the lenticule, the donor lenticule. So in cross-section profile, you can see either it is donut or a ring-shaped lenticule. It can be a concave-shaped lenticule, or you have the convex-shaped or the planar lenticule. So any one of these lenticules, depending on the publication you have read, a pocket is made in the host cornea with the femtosecond. The lenticule is also made with the femtosecond laser, and you just push it into the pocket. So if you see this review, this meta-analysis published in 2021, so there are different publications across the board with different lengths of follow-ups. The different parameters which are assessed is the uncorrected visual acuity, the best corrected, the spherical equivalent, the maximum keratometry, the mean keratometry, the max keratometry, and the Q value. So if you see this publication from India, so it had a good number of patients included, and the follow-up also ranges for quite a period of around 6 months to 1.5 years. So basically, if you see the spherical equivalent, there was definitely a marked reduction in the overall spherical equivalent and the reduction in the mean keratometry and the maximum keratometry as well. But you need to have an access to the lenticule and also the femtosecond laser, which is not easily available across all centers. If you come to the other modality, one is the intracorneal ring segments. You have different segments which are made by different companies. Out of these, only the Intex and the Intex SK is approved by the US FDA. The rest are not USFDA approved. They're still available and used in the European continent. So you have Intex, you have Kera ring, you have Ferrara, and the Mayo ring. So you see the arc length varies across the different segments. You have the maximum choice in the Kera ring and the Ferrara ring in terms of the arc length. The cross section of these rings varies. The last three are triangular and the Intex is hexagonal. The Intex SK is elliptical. The thickness, basically more the thickness, the more the flattening effect which you will get. So the Intex is available in the 50 micron increments. Also the Kera ring and the Ferrara ring. In the Mayo ring, it's not very clear. The optical zone also varies. So you can customize the segment size depending on the flattening effect you have. So again, sorry for the busy table. So this is from the 2019 publication in which they've included various studies. Again, if you see a combination of one ring, two rings. So if you see this publication from 2014, in which a manual method was used to create the intrastromal tunnel, the Ferrara ring was used, 36 eyes were included. The follow-up period was around, one part of the study was 5 years, the other part was 10 years. However, if you see, these vital parameters were not studied in their publication. The only parameter was mentioned was how many gains of lines of corrected distance visual acuity was just mentioned. So in the 5-year follow-up, 56.5% of the patients in their group gained 2 or more lines. Over 10 years, 66.7% gained 2 or more lines in their publication. If you just see just above this study, from 2016, 409 eyes, so the sample size is quite long. However, the follow-up was not so much, it was only 6 months. But they have studied all the parameters like the change in the spherical equivalent, change in sphere, cylinder, and also the gain in lines. Again, at 6 months, around 54% gained 1 or more lines in the implantation of a Ferrara ring. So there are numerous publications, but the follow-up are not actually very extensive. Most of them are around 6 months. Some of them are as extensive as 5 and 10 years. So if you combine this intracorneal ring segment with the cross-linking, again, this study was retrospective in 2018, in which the order of procedure was different in the different sample sizes. One was the ethanol-assisted Epion CXL was done first with the ring, then same day CXL and Intex, and the other was the Intex was done first and then the CXL was done later. So across all the three groups, the gains of lines were ranging from around 42% to 51%, who gained 1 or more lines in the corrected distance visual acuity. Then the other review watch was combining intracorneal ring segment with PRK with cross-linking plus or minus intraocular lens implantation. That was only one study. The order of the procedure ranged from the PRK and CXL, which was done 9 months after the ring segment implantation. The other study said that the wavefront guided topographic PRK and accelerated CFM at least 1 month after the ring segment implantation. And the third study was the intracorneal ring segment, then cross-linking, and then 6 months apart after that, the PRK was done. And the last study, which was ring segment, cross-linking, IOL, and PRK, minimum 6 months were given between each stage of the different procedures. But all of these studies basically showed that there was a significant improvement of all the visual acuity, the reduced keratometry, sphere, and agmist, but there was no change in the central corneal thickness and the coma values. Again, the other studies also reported significant improvements in the corrected distance visual acuity and a reduction in the keratometric values. If you go to the cross-linking, so we have different modalities which are focused. One of them is focused on increasing the oxygen delivery, because Charuta has shown the oxygen radicals are a key player in this. So the epi-off pulsed high fluence protocols is aimed at increasing the oxygen availability in the stroma for the reaction to proceed faster. The other study is increasing the ribofluin, increase residual ribofluin in the stroma. So that is basically the enhanced fluence pulse rate iontophoresis, in which an electrode is applied to force the riboflavin into the cornea. The one are the customized protocols in which the central island is left intact around that and the epithelium is removed around the cone. And one is the combined, in which is the CXL plus, in which you can combine the CXL with the other modalities as shown before, like ring segments, PRK, IOL, and whatnot. So this review article in 2019 in IGO is basically divided the studies based on what they have done. So first was the corneal cross-linking using hypoosmolar riboflavin, basically for thin corneas. So in all the studies which were published right from 2009 to 2014, with around 20 to 30 eyes, so the riboflavin concentration was 0.1% in 2 studies and 0.5. The follow-up, maximum follow-up was 1 year in the studies. The topography was very stable. There was no endothelial cell loss in 2 of the studies, and none of the studies, 3 studies, reported any complications. If you see the transepithelial collagen cross-linking, and around again ranging from around 20 eyes to 50 eyes, with a mean follow-up of around 1 year, 1.5 years to 2 years. The first 2 studies which are important is the first one said that it was stable about up to 12 months. And then at 2 years of follow-up, the worsening started. And the second was even more alarming in the sense that the progression was noted in 46% of the cases. They didn't study the endothelial cell loss. And one study says the complications range from epithelial defects and loose epithelium. 2 studies surprisingly said the topography was stable. And if you see the iontophoresis assisted transepithelial collagen cross-linking, so around 20 eyes and 80 eyes in one study. So the follow-up was around 1 to 2 years. 2 studies said that it was stable, no endothelial cell loss, no other complications. But the third study with 2 years of follow-up and 80 eyes said that in the iontophoresis group, there is a failure rate of 20% compared to the 7.5% in the conventional Dresden protocol group. And lastly, the collagen cross-linking with the customized epithelial debridement. So 2009 onwards, Camionis, and then up to 2017. So 19 eyes, the follow-up was for 1 year. The topography was stable. Endothelial cell loss was reported in one study, but no other complications. The other 2 studies with around 1 year of follow-up, the topography was stable and no endothelial cell loss. So that's the brief literature review. So I'll go back to the panelists.
Thank you, Aditya. I think with this, we open the discussion to all the panelists. So I think starting with Dr. Rajesh Fogla, sir. Sir, can you have your comments on the article?
Well, my comments are something, the points which Charuta has also alluded to, in the sense that I'm not very much convinced by the results that have been published in this paper. Number one is that it's a retrospective study, and even in the inclusion criteria, using that 1 diopter of difference as a sign of progression. I don't think that's correct, because a lot of patients in repeat measurements also show a variability of up to 1 diopter. And they have a follow-up which is only of 1 year. And we know that progression can happen beyond 1 year as well. And within that 1 year follow-up, they have shown 90% success. That means 10% of the patients progressed. One of the other conclusions they have made is because they had variable depth of demarcation line, they kind of concluded that the depth of demarcation line does not indicate stability or the strength of the cornea that's been increased. And the depth of demarcation line only a change in the corneal microarchitecture. So somehow I feel that in the discussion part of it, they have, just to make their study more positive, they have kind of modified a few of the points which are still not very clear. And in my practice, I think it makes more sense to do an accelerated protocol where we know that the changes are much more superficial in the cornea. So it would make more sense to do a similar, use the accelerated protocol for a reduce duration of time based on the corneal thickness. I think these are the few points that I think which come to my mind after reading this article.
Thank you, Dr. Fogler. Dr. Himanshu, since you've been doing the thin cornea CXL and you have your protocols at Narayan Vidyalaya, can we have your comments?
Yeah, so I put the link of the calculator there. So there are a lot of things. See, one thing which we have to remember is that when we are doing cross-linking, it's not about how thin cornea I can cross-link without frying up the endothelium. It's about what you want to achieve there, final destination, what I call that's like, how are you going to visually rehabilitate the patient? If you're able to cross-link 100 micron cornea, but if you're not able to visually rehabilitate that patient, does not make any sense, right? So it's not about how thin you go. What is your plan next to it? Now you may go thinner, but if you're not able to cross-link, you're not able to visually rehabilitate that, then you are sort of reducing your success rate of either big bubble or certainly wasting your resources. Another thing, so when we talk about cross-linking thin cornea, we are trying to do like avoid endothelial damage, which can be done by either adding some tissue or material in front by pushing the endothelium away, right? Which is whether it's a smile lenticule or any lenticule, or whether it's a contact lens or something, you're sort of pushing the endothelium away so that it does not reach the cross-linking effect, does not reach there to the endothelium. It certainly would reduce the amount of cross-linking, because maximum amount of cross-linking occurs superficially. Now, does it still matter? We really don't know, because we really don't have an answer that how much do we need to fry the cornea? Do we need a demarcation line at 70% depth? Or nobody has idea. If I ask you a question that after cross-linking, if cornea stabilizes but does not flatten and does not show any demarcation line, would you call it success? Of course, you all will agree that it is successful. So then why do we go by such kind of thing that if we are able to, as Dr. Fogler said, that if we are able to cross-link by possibly increasing the fluence or something, that's still fine. So another way is by reducing the depth of treatment, which can be by increasing the fluence, like accelerated cross-linking. In accelerated protocols, it becomes more and more superficial. So your endothelium is sort of saved, or by reducing power, or by reducing the time, what this study has done. But end of that, what we are talking about is, are we not frying endothelium? That's it. Now nobody has idea that how much cross-linking is enough, and hence every procedure has a role, and you can have every procedure which you can show long-term outcome and say, oh, it does not damage the endothelium, fine, it's fine, absolutely fine. Oh, it does not actually progress, it's fine. So in probably cross-linking most of the things, and in fact, if you look at Damien Gatinel, he says, if you stop rubbing, that itself stops the progression. We laughed at him, but we all now ask history, and we all are pretty sure that the eye rubbing, direct and indirect, has a huge role to play. So thin cornea cross-linking, it's a vast subject. Everything works, whatever works in your hand, whatever protocol you use, it's fine. Coming to the calculator which we use, well, that was developed with the Ebrard Pearl's data. So Sperl had shared his data with us, and about different corneal thickness and different riboflavin concentration. And based on that, we made a calculator. I put the link in this thing. Again, end of the day, whatever works in your hand is actually fine.
Thank you, Himanshu. So with this, I want to ask Susan, ma'am, since Dr. Susan is, you have used contact lens and the lenticule over the cornea, and you have done cross-linking in thin cornea. So how do you compare this protocol versus the treatment modality that you have used?
Thanks very much for inviting me here. I'd just like to say that I have not used the lenticule over the cornea. I have been doing the CXL technique since 2012, and being a tertiary institute, we have a huge number of cross-linkings that happen. We have on an average about a cross-linking a day, 25 to 30 would be our average number, and many of these are very advanced in the sense thin cornea cross-linkings. So we've been doing this since 2012, and the very fact that we are still continuing to do it without really going to too many other techniques shows that we are quite successful at it. Just regarding this particular paper, I would agree with Rajesh and also a lot of points that both of them said, Himanshu. There is some weakness in this paper, not just the points that they mentioned, but also the fact that if you look at it, it's mentioned as ultra thin cornea cross-linking. Now, when you say ultra thin, what is the kind of thickness that you would think of? Because we've all been doing thin cornea cross-linking for very long. This is not new. 300, 350 and all are very commonly done by all of us. 320 and above would be something that I would very happily go ahead and do. But when you call, say, ultra thin, and it's kind of a revolutionary kind of treatment that is now going to be possible, and you can do very, very thin corneas, what you would expect is more of about 250, 280, 290 kind of corneas. But if you look at the study, there were only about 4 patients who were that thin. And a large majority of the patients were already in the group which all of us have been handling and have had good experience with. And also, if you look at the amount of cross-linking, it's shown as about 130 to 140 microns in 200 micron corneas. Now, again, the question arises, is this sufficient? As Himanshu said, we don't know. We really don't know how much of cross-linking is required for the cornea to stop progressing, which is also the reason why, when CXL is said to have 30% less effect, this is something that I have said right from the beginning, that CXL does have 30% less effect. We said this in our very first paper that was established. But the fact again remains that this 30% less effect, we found that it is quite sufficient for all our cases to have very good effects. Some of the other points that this paper again kind of makes you think about is that, of course, what Farhad himself says is that the endothelium has not been studied at all. So when you're talking about the safety, I think specular count is one very important thing which you need to be looking at. And if a paper is, saying safety without specular count, it really kind of raises a question, because we all know that corneas with as low counts as 500 would still maintain clarity. They're not going to get edematus. So what is the exact the safety that has to be established is still, I think you really require large number of patients, and especially when you say ultra thin, I think you need to have patients in that range. Coming to that, now I will say, do you really want to cross these kind of patients who are so ultra thin? You act like Himanshu said, you have to finally get vision for these patients. You have to be able to visually rehabilitate them, and also we need to know if this kind of cross-linking is going to be stable in the long term. So if the cornea is so extremely distorted, or if the cornea is so extremely thin, I might feel more comfortable doing a talc rather than a cross-linking in these cases. There's also, if you look at it a little more closely, there's the demarcation line to the endothelium. The range is given as 0 to 250 microns, which again, I start wondering why the minimum range is 0 microns. The corneal thickness, as I said, there were only 4 eyes in the really low category. The Kmax shows a flattening of about 8 diopters in many patients, which is a substantial amount of flattening, and it starts to make me think, was there a significant amount of haze or some amount of scarring or whatever that could have happened. And also the posterior densitometry, which is again one thing that was studied, was also significantly increased, and posterior densitometry is about 60 microns according to this paper itself. It's studying the last 60 microns, which is right next to the endothelium. So if the posterior densitometry is increased, then that means there are some changes that are happening very close to the endothelium as well. So taking all these things, I think really we need to think. Also, if you look at the patients, the paper says that so many patients, I think 18 or whatever number, were above 40 years. But if you look at the patients above 30 years, that's again a significant chunk. So taking the patients above 30 and 40 together is a significant number of patients. And we know that in these patients, progression is automatically slowed down. Beyond 30, progression is slowed down, and the patients who are really going to be affected are the much thinner, are the much younger patients. I think a lot of points, there are actually many other points which kind of decrease the value or decrease the the amount by which we say that, yeah, this is an authoritative paper and we can definitely go ahead and change our practice patterns based on this paper. I think, yeah, that is that. I'm not sure what else you had asked me. You had asked me something else about
You were doing the contact lens based CXL therapy. So have you been practicing thin corneal duration based therapy, and what is
no,
your answer?
not at all. We've been doing accelerated cross-linking combined with CXL. Now, what I do sometimes do the small changes that I do make in this, other than the standard one that we use. The one that we published first was the standard Dresden protocol, but for many years now we've been doing the accelerated CXL, which unfortunately I've not yet published. But there are many other publications around the world and from India which now authenticate it. The small changes that I do make sometimes is if you have a very localized small area of thinning, which is going to take you beyond the extent that I would consider safe for cross-linking. What I do is I just retain the epithelium there in that area, and then do a CXL for the rest of the area, epi off. So it's a sort of combined epi island with CXL, and that's only for very small localized thinning. So sometimes I combine that. And sometimes if I'm just off, sometimes if I've not reached 300 microns of stromal thickness, because my contact lens adds about 100 microns. If I've not reached 300 microns with just the CXL, I maybe need about 10 or 20 microns more. I put 1 or 2 drops of distilled water, and that takes me immediately. Within about 3 to 4 minutes, it takes you up. So this is a combination which I do in those very rare cases. Most of the cases, 90% of the cases, 95% of the cases, you don't have to do any of these techniques. But very few patients, I might do this.
Susan, ma'am, you said that CXL has 30%, it's less effective, 30% less effective than the other modalities.
The UV transmission is decreased by 30%.
In these cases, increasing affluence would have an added role, to get a good cross-linking.
You could, but again, the question is how much cross-linking do you need? As Himanshu said, no one really knows how much you
Parul,
need.
it goes other way around. When you increase fluence, it goes more superficial.
Decreases.
So increasing fluence is, that's why Dresden protocol goes more steep. And as Susan was saying, because they use Dresden protocol, they are getting that haze which is so deep and which makes it little dicey, that is it actually going deep enough to touch up the endothelium or something like that.
Okay, so I think I have this thing, total energy that you deliver. So normally I think we are using 5.4. So if we increase the total energy, which is 7.2, yeah.
But Parul, whatever way you think about it, if you're having reasonably good results with what you're doing, I don't want to change it. You understand? I feel my cross-linking is sufficient because I don't see patients coming back with progression. So if I am having that, I feel that the amount of cross-linking I'm getting is enough. Why would I want to change it?
Yeah.
Very, I mean, we blindly follow somebody who tells us that, this is what demarcation line, this is what is called cross-linking. But other than that, if you actually think about it, in India, majority of us are now doing accelerated cross-linking. Majority of are now using non-dextran based riboflavins, which itself swells the cornea. And if results were so bad, in fact, nobody would do anything. And if you, a couple of years back for Kera, I had done a survey of corneal surgeons in India. Maybe next time, I didn't remember, I could have put it. They're probably largest in the world, all our cornea surgeons put together. And majority of us are doing something where conveniently, as Susan was saying, we have taken 400 micron as with epithelium. So according to their standard 350 micron, we were doing from ages, even before all these things, we were doing 350 micron from there. And now with all these riboflavin changes and accelerated, the data which we have is mind-boggling. So if it was so bad, then possibly India would have huge amount of progression or retreatment of keratoconus, which is not there. So as Susan said, it's working in our hand. And just because somebody else feels different, it may not be indicated to change.
So we'll go, Dr. Mukesh sir, can you share your thoughts to this and add some points to this discussion, and then we'll take up the audience questions in the chat box.
See, as far as the philosophy of this paper is concerned, I agree with this that probably the duration of the energy or the UV radiation should be different for 300 micron, for 350 micron, and 400 micron. The philosophy which I have a little doubts about, one is they are checking the pachymetry at the presumed thinnest cornea point, which is not easy. I've done intropachymetry extensively for all different types of riboflavin which were available, and it is not possible to go to the thinnest point. So what I was taking a reference at that particular point was when I studied the intra of variation of the pachymetry was whatever was on the pupil centermost point. But because if you see that the variation of 210 or 220, just 10 ultrasonic pachymetry. If it is not on the thinnest point, which you cannot judge under a microscope any which way, you will be way off your mark. So that is the major concern. And practically speaking, I've seen 90% of the people who routinely do cross-linking do not have access to intra-pachymetry. So doing it based on an intra-pachymetry itself makes it a difficult procedure. And then to get to the centermost or the thinnest most point, intra will be very difficult. So practicality of following this protocol is difficult. And what Himanshu said, all of us, I've been routinely, we have been doing 350 microns very routinely because most of us were following 400 micron as the limit. And the different riboflavin which I have used, there is a lot of variability or thinning if you're using a dextran, riboflavin or dextran. For the past 3-4 years, most of us have shifted to the HPMC riboflavin, which does not have dextran. It swells up the cornea for about 75 to 100 microns, which is very sufficient to do something like a 325 micron cornea. I've been routinely doing 325. As Susan also said, there's nothing ultra thin about what they have mentioned. 325, 350 is what I have been routinely doing with HPMC. It has never really bothered us. So the philosophy is fine. The algorithm probably would also be fine, but I find it a little impracticable to do it on table, is my concern. So what has been working for us, for me, HPMC riboflavin has been working for the past 3-4 years. So I don't really see why should I get into this trouble of doing an intro pachymetry, arranging ultrasonic pachymetry. So that is, and I totally agree, you cannot comment upon the endothelial safety when you have not done specular at all, which was another point which was raised by Dr. Susan.
Mukesh, I understand that they
So-
have done intraoperative pachymetry because they wanted to actually categorize after using hypotonic riboflavin, what is the minimum thickness that they are getting. And then they are probably taking the duration of therapy. So they are not taking epi off in the beginning of the procedure. They are taking it after using the hypoosmolar riboflavins, which in turn also swells up the cornea. So I think there's a conflict.
No, I think what Dr. Mukesh is saying is correct because, basically you try to kind of figure out which is the thinnest point looking at your Scheimpflug image or something like that. And then you can kind of, if you want, you can mark it on the cornea. But then it's a little confusing and it's a little impractical to be able to exactly mark the exact spot where it is so thin. So it is very possible that you might go wrong intraoperatively when you're trying to measure. What they said in this paper is that they take 10 measurements and take the thinnest. Take whatever value comes thinnest. That's one way of doing it, but there are always limitations to those techniques.
They could have very easily done a prospective study as well, using the same principles and with the modern imaging techniques. It was very easy. They could have had their retrospective data and they could have validated it by looking at prospectively and see if there was any difference between the cases, what they enrolled then and what they are looking at now based on the current technology and maybe the current literature in terms of what you have, whether it's the M protocol. But so basically for me, it's a good paper to read, but not something that I would apply in my clinical practice at this point of time. And as Susan said, that majority of these patients actually don't need cross-linking. First of all, if you look at them, unless they are wearing scleral contact lenses, quite a few of them are unable to have a regular RGP lens fitted on their eye, or even if they are fitted, they don't fit very well. So unless the patient is willing to wear a scleral contact lens with such steep corneas, I don't know, by doing a cross-linking, and let's say even if we make this keratoconus stable, what are we achieving visually for the patient? The patient comes back. So that's what we see in our practice. Patients undergo cross-linking elsewhere than they are in your clinic and asking, Doc, I can't see. What can you do for me? I had cross-linking earlier, but it's of no use. So just by saying that we have made a keratoconus stable, I don't think that really makes any difference for me. In fact, my cross-linking rates have really reduced over a period of time, because we are now in the process of accumulating data. We are seeing strange corneal lesions in patients who have had cross-linking, the Dresden protocol 12 to 13 years back, all done at tertiary care centers. And they are having a non-inflammatory stromal loss, as if the stroma is dead. And you're getting a cavitation in the stroma, and you're getting the decimates, the pre-decimus layer and the epithelium coming together. And these patients with extreme flattening of the cornea, and they have to have a corneal transplant. So as if the stroma has lost its ability to regenerate. And some of the eyes where we have done the keratoplasty are dark, we send it for histopath, and the histopath shows that there are absolute lack of keratocytes in the stroma. We know that there is a stromal turnover, which happens 8 to 10 years over a period of time. So what if the cross-linking that you have done has cleared off all the keratocytes and the stromal regeneration is not happening? So after a certain period of time, so you will have, and when I posted some of these cases in a group, at least 7 or 8 people have had similar cases in their practice, each person having 2 or 3 cases for which they have done either a keratoplasty or the patient is not seeing very well. So I'm pretty sure if we do a survey, we might find a lot of people who would have seen these kind of cases, but they have labeled them as, you know, excessive cross-linking or corneal burn because of hot spots or whatever it may call it. But this is something we need to investigate further, because there may be a large number of patients who may be having some long-term sequelae of cross-linking, which we are not currently aware of.
Also, interestingly, if you look at the article, retrospective data analysis, that too done in a long period of span, then they gave us a nomogram where they gave us every 10 micron how much to change. It was never intended to study like such kind of thing, but how did they come up with that kind of magical number through this study, which is again quite baffling to me. Also, very interestingly, if we look at such kind of study critically, certain interesting thing like they said excluded the patient who did not understand about the study. It was retrospective data analysis. You did the study now, and how would that patient you excluded who did not understand about your future study? I mean, that doesn't actually. And they have the ethics committee approval now after, so that approval is for data analysis. But then you are doing a study which is not approved, where you are not sure about the safety, and I don't know, came that time. Was it for the study or something? So I mean, this is just for the heck of discussion, but if you look at many times we criticize our own studies, but they're no different. They also
Aditya, we can't hear you.
Yeah, so I think Dr. Maninder is also on the panel because he is the biostatistics expert. So, sir, any comments regarding this article and the way the statistics were dealt? Any lacunae or any abnormality?
Please call me Maninder. Fine. I'm not. So I guess statistics were very simple. They were not they were pretty straightforward. The only thing is, I agree with the previous speaker that in the exclusion criteria, they have mentioned that patients who could not give consent for the study were excluded. In a retrospective data, you don't expect consent for a study. So there is some problem. Probably they had clinical data early on, and or they collected data. I was just trying to find out whether they had given the date of approval.
I thought they said, Charuta, you said 2016
to 18
or something.
So no, date of approval is not there, Dr. Maninder.
Yeah.
And
Yeah.
the thing is, they've said that it was a retrospective data analysis, and then the very next statement is patients were enrolled. So
Yeah.
that statement itself gives away that there is some lack of clarity as to the study design itself. Was it prospectively planned and then retrospectively analyzed? Is there something like that?
No, but I think what they tried to do was that even though they were recruiting patients from the patient database system, they took the consent from the patients.
Exactly. Yes, that was another point. Why do you need consent for a retrospective study?
No, sometimes given probably it was in Switzerland, right?
Yeah.
Yes. Yes.
Yeah. So patient data, like, the patient guidelines may be different. It may not be required in our scenarios, but sometimes when you use retrospective data, maybe it is required by them. I don't know. But they have mentioned that data were collected through a search in the patient database system, and a written consent was received by all the patients. So I don't know. I don't know. Usually in a retrospective data analysis, I agree with you that consent is not required because they are clinical data, but I don't know whether it was required by their regulatory body or not, or their ethics committee. That's one thing. So otherwise, the statistics are pretty, they're very straightforward. They've not done any elaborate tests. The only thing I wanted to add to your discussion was sometime, like when you draw the line, the equation line, if you use for regression, then it's usually the least square distance. That's just a jargon which they use, like the distance which gives you the least squares between the line and each of the data points, something like that. So that's the only thing. Otherwise, I don't think they used any regression or anything. They were pretty straightforward t-test and comparison of medians.
So, Dr. Maninder, is that possible where you are now? Am I audible?
Yeah.
So is it possible when you have a limited data, what they publish, and then they come out with a protocol where they have every step, every 10 micron steps of suggested protocol. So won't it be extrapolation beyond data because they don't have data for those kind of things?
Yeah, so they have not given the analysis for that. They've not. But generally from...
so if you look at the number of patient itself, they don't have as many number of patients to fall into every steps what they have been, they have given us as a sort of suggestion how to do.
So the thing is, the discussion is becoming more theoretical, but a linear outcome is always more robust than a categorical outcome. So when you use a linear outcome, even though the numbers are small, the predictive this is much better than a categorical outcome when you have a yes-no kind of a comparison. So yeah, I agree with you that they should have told us how they got it. And sometimes in linear prediction, you do not have exact numbers in the categories, but that's why it's a predictive model. Like that's why it's called a predictive model, that instead of this to this, if you would have done for say 300 to 320, this is what you would have expected. That's an expected predictive model, but they've not described any of that. The analyses are pretty straightforward. The analyses are on the data. That's it.
But then again, we are assuming that thinner cornea of 200 micron behaves same way as a cornea of 370 micron or what they call
fair enough. So that is the biological plausibility of data.
Yeah, so that linear extrapolation.
So whether it behaves linearly or not, that is something they've assumed a linear
I think little bit beyond data.
Yeah, I agree with you. They've assumed a linear relation, whereas it may not be a linear relation, as you've suggested. So that's the biological perspective. Agreed. But that has not been shown in the paper.
Yeah, true.
So I don't know how to evaluate
So
that.
they've mentioned it in a previous publication, wherein they calculated a stiffening factor in murine, porcine, and Leavenite. That's how they reached that table. But Dr. Maninder, if you can tell us whether that line, actually the trend line, is actually able to tell us whether it's following the protocol, the table that they have given, because a lot of the points are much away from where it should be.
Well, that's what I said. So the line is always the one which fits best from the least square distance. So basically the way it works is you calculate the Euclidean XY distance from the line and the point, and you square that distance, and the sum of the squares, which gives you the least value, is the best fit line. It's more complicated, but yes, you wouldn't get a line which goes through points. You'll get a line which is the least this, but whether, so I've not read the previous paper. I cannot comment on that, whether they had tested the non-linearity or not. But in this case, what it seems like, it appears to be slightly linear,
But also I have a question. The number of patients who are actually, who could probably be called as fitting into the ultra thin, the ultra thin range would be only four. So on the basis of those 4 patients, is the predictability still valid? Because, and even if this is a predictive model, it doesn't there need to be one more study to validate this predictive model?
So they've put up a randomized trial on the clinical trials registry, Dr. Susan, but I'm not sure what is the current status.
Does that trial also include specular microscopy?
It does, yeah. Okay. That one. There are far more criteria for inclusion and exclusion, and also documenting progression.
So I think
now I think we can take
small safety study or something like that. Maybe.
Yeah. Probably it's a small mid-step study between a bigger study, and it should be taken that way. But my hunch, my 2 cents is that, if we criticize every study has a problem. You just interpret the study with the limitations of the data that we have and take it that way. That's it.
Very true. All we want to know, because I think in at least in our Cornea fraternity, this was projected as a landmark study, which is going to change everything, how we see. And that's the reason why we were criticizing. And of course, the aim was not to prove that they've not been done. I mean, Dr. Hafizi has been doing quite good work. But at the same time, I think that wow was created in the fraternity is, I think we should be waiting a little more.
I think basic thing is that Dr. Hafizi understands what he means by when he says 400 or sub 400. A lot of our readers will not understand that. They will just take this as as an approval and go ahead and treat a lot of patients with techniques which may not be beneficial for the patient. So I think it's important for people to understand what this paper actually means and how the data should be, or the results should be applied in clinical practice. It reminds me of a very similar paper in one of the Canadian meeting. David Lin from Canada, he was showing results of topography guided, surface ablation in keratoconus. We all keep a thickness of 470, 480 when we are choosing patients for that, and we tend to leave behind a residual bed thickness of about 400. He was showing cases of with thickness of 270, 280, and he was going ahead and doing topography guided ablation. So I stood up and asked him that, is it justified? Why do you do it? He says, what will happen? They will become more ectatic, and then you will do a surgery. But he says, out of all my patients, 80% of them don't progress despite having a laser ablation. So only 20% progress. They anyway need keratoplasty, so they would have. So I'm by doing this treatment, I'm not causing any harm. So that's his justification of doing topography guided ablation in thin corneas. But taking that, we cannot go back and in our patients start ablating all corneas which are 300, 270, 280, saying that, oh, David Lin is doing it, so I will also do it.
In fact, interestingly, Rajesh, similarly, there are a couple of publications on PRK as a refractive surgery done on formoplastic keratoconus. Now, the thing is, they're saying that it may not progress, and it has not progressed, or progression rate was pretty low or something. Now, looking at that, do you think that we all would start doing cross-link, doing refractive PRK in keratoconus patient? No, all refractive surgeon would still want to rule out keratoconus and would still, so as you rightly said, it's such a robust tissue, cornea, it's taking all the insults and still holding on.
I think we are having some questions. So can we take those questions? Aditya, can you stand?
So the first question was basically, this is for all the panelists, is suppose you see progression after doing a transepithelial cross-linking, can you repeat the cross-linking?
So answer is, if first time it didn't work, why would it work second time? Unless we find out the reason, there's no point doing same thing again, which didn't work first time. So either the inflammation, eye rubbing, or the technique itself was an issue, and that's how it had a problem. So second time, if you are doing the same thing, wouldn't make any sense to me.
I also have, I don't have too much experience actually doing repeat cross-linkings, fortunately. But, if at all anybody is considering repeat cross-linking, I would say please make sure again, Himanshu said why it happened. Second thing, if by chance it is a thin cornea, please check your specular microscopy before doing it, and not just the central, but 6-quadrant specular microscopy. And then if you're doing epi on, I would suggest do epi off. I think most corneal surgeons would agree to that.
Yeah. So
the second question is basically, anybody amongst us has experience using the slit lamp cross-linking device? I think it was developed in Switzerland maybe, and is it available here? Anybody has seen a demo or anything?
I think that's again Farad's pet project, lamp delivery system, and it's actually a good idea because you can actually take it to transport it, take it around, especially in countries where you don't have the facilities to do cross-linking. You can do this. Of course, you need to be very careful about sterility, but cross-linking as such does take away some of the infectious organisms, so that's one helpful thing. But however, still be careful. And yeah, Farad is very enthusiastic about it. I haven't personally, of course, got any experience. I don't even think it's available in India as yet. I'm not sure.
So I think one part is about the killing of the organism there, as Susan was saying. But second part is the sterility part, where it's not while doing cross-linking, there are going to be bacteria there, or after. Exactly. Now, a cross-linked tissue behaves so weirdly because there is severe keratocyte rarefaction. There's altered milieu there, and which can, if gets infected, can actually progress really fast and can be quite disastrous and can melt quite fast. So with the bacterial loads in our ambient environment, I would be very skeptical to do anything in not so sterile environment. I don't think our OTs are that expensive where we have to pay by minutes, like how in West they have to do, or we surely can take them in sterile environment and do cross-linking.
Since we are running short of time, I will just take the last question, and I would request every panelist to give a single line answer for the same.
Well, if I can just interject and just say one thing to all the viewers, cross-linking is a great technique, but it should not be taken too lightly either, because often sometimes, unless you're really familiar with it, and especially thin cornea cross-linking techniques and all, don't just jump into it without adequate preparation and just by reading anything. Because one is, sometimes when you get the scarring post cross-linking, it's extremely irregular. You'll have this localized scar and you'll have extreme hyperopia there, and it leads to this kind of irregular astigmatism, which is very difficult to treat other than with a DALC. So please do be careful about just blindly going and doing cross-linking.
Yeah, so going to the last question. So what protocol would you follow if you have a cornea which is 300 to 350 microns for the cross-linking? So Dr. Fogula, what would you do? Which protocol would you use? That's the last question that we have.
I would definitely use an accelerated protocol, and depending on the thickness of the cornea, I would decide the duration.
So would you use hypotonic or HPMC based riboflavin?
I have been using HPMC, which kind of swells the cornea as well. So I've been comfortable using it. So why change? I would use an HPMC based riboflavin.
So Susan, ma'am, yours?
I have been doing CXL, and I think I mentioned my protocols a bit earlier.
Mukesh? Dr. Mukesh?
HPMC 9 milliwatts for 10 minutes accelerated. I do not go to 18 milliwatts. 9 milliwatts for 10 minutes
Dr.
with
Himanshu?
HPMC.
Same thing. And I hope what you are asking is after soaking or before soaking?
I don't know. The question was there as 300 to 350. I think after soaking, we should take it.
And
Or
then
before soaking.
before
Yeah.
soaking, and then as Rajesh said, I think we all are using HPMC accelerated one. Personally, I have been using 18 milliwatt for a really long time and I have really great outcomes. I do not have anything which is starkly different from anything. So again, we come back to the same thing, that we just believe somebody tells us that, you know what, 9 only works, anything more than that is useless. Maybe in their population, their hands, their machines and their riboflavin, ours is not as bad. So be very careful about what Susan said. Be careful about what you are doing and follow it up properly so that you know what you're doing is right.
So nobody is using 3 milliwatts therapy for even thinner corneas.
Thinner cornea, 3 milliwatt would be bad. So I accelerated would be more superficial. So thinner cornea, the safer bit is accelerated rather than the Dresden protocol, which will go much
talks
deeper.
about 3 milliwatts. That's why. And I think there is one more question, is that what is the role of using only stopping eye rubbing as a main treatment to stop progression as propagated by Dr. Gatlin?
So again, it boils down to same thing, that are you ready to do that by stopping? We must stop direct and indirect eye rubbing. Are you going to give that treatment to your patient, and would you be happy to do that trial? Go ahead. And if you think you can follow it up and try it out, try it out. If it works out in your hand, you have to ask that question to yourself.
Yeah. I think we've already shooted our time. So with this,
This is one question I think Soham asked about two distinct groups of KC with thin corneas. One is thin cornea with high case and one is thin corneas with moderate case. And any difference in the outcomes. For this, I would just say that if you got these very high case, you can combine it with these ICRS techniques. There's already a discussion about ICRS techniques. CARES is another technique which I think could be added to that discussion, where you can get large amount of flattening. Because you are using allogenic tissue, you can go much more than what you would do with traditional synthetic ICRS. So I think in many groups today, I just shared a patient with 82 diopters of K-max, where I used CARES to flatten it down and then combine it with the cross-linking. And the patient actually improved from 3/60 to 6/6 part, 6/12 part uncorrected and to 6/6 part best corrected. So when you are having this very high case, flatten it out and then do the cross-linking.
Yeah. I think, thank you. With this, I think we would like to conclude the second session of Journal Club. And I would like to thank all the panelists and all the attendees for the wonderful discussion that we had. And we will soon be coming with our third session, which will be again after 2 months. And the date will be declared soon. Yeah. So thank you, everyone.
Thank you.
Thanks a lot. Thank you. Take care.
Team JC, thanks a lot. Thank you.
Thank you. Thank you.
And everybody, 9, 10, 11 December, CARACON 22, registrations are open. Please go ahead and register. See you there on 9, 10, 11 December.
Thank you.
Thank you. Good night.
Thank you, everyone.
So most of them have left, so we'll stop, sir.
Yeah, we can stop. Dr. Paras is there? No, we'll.
Dr. Paras is there. Few attendees are also there.
Okay. No, so we can just. Okay. Anyway, I'll talk to Dr. Paras later on that.
Sure.
Sure. Bye.
Thank you.